Okay, it's streaming already. Okay, it's fast. Janelle, you have to go offline. And this sound is on as well.
Good evening.
Good evening. Oh boy, I just barely made it.
Yeah.
We have to talk after this.
Yes, sir. Please.
Hmm.
Yes, sir. I'm just looking at this thing to write an invoice here.
Okay.
The class is done, Marshall,
Okay, you're finished with everybody.
for now.
Now the mentorship begins.
I have to tell you some jokes.
Hmm.
This is island life.
Hmm.
Oh, well.
Hmm.
Oh, well.
Hmm.
Got off the phone with one of the clinicians and she says, I am not happy. I don't think I'm going to sign this contract.
Okay, okay. Hmm.
It smacks of nepotism.
Oh, really?
Mhm.
Okay.
Big time.
Hmm.
Big time.
Oh, boy.
Leave me out of it, darling.
Yes, yes, yes. They work their way through.
Yeah, yeah, yeah. So how are you?
Not bad.
Yeah.
Busy.
Yeah,
But I mean, we're coming to the end of the academic year, so it's a bit of a wrap up
Mhm.
to be done.
Please God. Yes,
Mhm.
yes.
Right.
Yes, yes.
Mhm. So I see Janelle and Georgia on. Janelle, we're not going live now on YouTube currently, or it's just saying that we will go on in a bit.
No, we're live right now.
Oh, we're live on
Evening.
YouTube. Oh my.
Evening, everybody.
Okay, make sure you can edit out.
It's fine, it's fine. I don't think
Before we
Nobody has
start.
joined yet.
Oh boy. And you can make Mrs. Hunt and myself co-host so we can screen share.
Sure. Yes.
Good evening, Jenny.
Good evening, Mrs. Houghton. All right, Prof. Co-host. Okay.
So how is life in Jamaica, Prof?
Well, I don't know. I have all these twists and turns. I mean, I don't know. It's a lot of the same things. The latest thing is that social media
Mhm.
lady who disappeared.
Oh,
Yes.
yes.
Mm,
I see that. I was reading
mm,
the news and I saw that. So
yes.
no idea where she.
They can't. I don't think they found the body, but they have arrested the boyfriend.
Oh dear.
For missing person.
Yeah.
So boy, these things can be good and not so good. So people do their social media thing, and it's a new age influencers.
Well, and also, it sort of puts you out there whether you
Yeah,
want or not.
right. Yeah, it takes a risk. But then, I mean, everybody pushes it as though it's just as simple as going out there, but it has its risks and benefits.
Mhm, mhm. I'm having a problem here in that every now and then somebody tries to log into my account.
Okay. Okay. Better watch it because that's what happened with me and the scamming. I actually just
Change passwords.
I disconnected that email from anything to do with the banking.
Ah, okay.
So I created another account, another email, which is I just use for the bank. So I don't put it on my phone or anywhere else.
Oh, and I'm not, and the bank is offering to put it on my phone. I don't want it.
No.
I want it on the phone.
No, I'm actually going back. So the less I have on my phone,
Yes,
the
yes,
better.
yes. I can agree with that.
Yeah, it's a little bit. I think I was kind of surprised at how quickly, because they're able to, just by cloning the SIM, they took hold of the account, and then the SIM was how you use for recovery of the email. And once they had access to the email, then it was just like they had access to everything, because they could go in and change the bank password and yeah, and to access the email, all they needed was access to the phone.
Mm-hmm.
the phone number. So once they look and they're getting, like, you can't remember the code, and it gives you the code, and they just go in and text, ask it to be sent to the phone, and they're seeing the numbers. You're not getting any of the texts because they've hijacked your number, and they're in your email, and then from the email they're in your bank account.
Yeah, I was telling Jason, I saw 4 requests in a month
Mm-hmm.
that week. The Outlook sending me a code to access my email account, but I didn't,
Mm-hmm. Yeah.
So
Mm.
I wasn't sure what direction to put. Which of my emails? That's the first
Right.
which one,
Mm-hmm.
I have an idea which one it is now. So
Yes.
Okay.
So this one, the bank one, is offline. Nobody should have that one.
That makes sense.
Yeah. Oh boy, you realize how interconnected everything is.
Well, and that's the loss of all of this technology. That's the
Mhm.
side to it.
Yeah.
Your privacy is totally demolished.
Yeah, they push you into it. It's not like you have a choice. They say, okay, no, we won't have any teller, we won't have any this. You have, if you don't do it this way, then you won't be part of it at all.
I did the presentation on burnout for Anita.
Okay.
It was interesting, she had 40 people online
Oh, really? Okay.
attended. She has done well developing her population there.
Right. Okay. So you've been guest speaking
Yes, boss.
for a number of us.
It's been a week to remember.
Yes. Oh boy.
Neighbor died. My
Mhm.
104 this week Friday, and he couldn't make it.
Wow.
Oh,
He was
man.
at home, or he was
Well, yes.
okay. So he's in hospital,
Oh, no.
Mhm.
I think he had briefly gone in because we missed him one weekend, but the care was back the following Monday. So
Okay.
back, but he was in failing health, and walking was really hard. But
Yes.
you miss him. He was a
Yes.
crotchety old person, but
Hmm.
yeah.
Oh boy. Determination to get to that stage.
But unfortunately, his wife is in a nursing home and she doesn't recognize anybody.
Okay.
Aware of what's going on.
Wow.
The children came and emptied the place, and it's for
Yeah.
moving on.
Wow.
Like that, eh?
Yeah. Life goes on.
Yeah, life goes on. Because it's Jason who sent me a text message one morning on his way to work. He said, "Mom, go outside and look. So and so and so. His stuff is outside."
Wow.
Oh my God. I was so devastated,
Yeah.
He and I had a relationship, I found him miserable at first and kind of
Give him a bread.
he was, very demanding and telling me what to do. And
Yes.
I sort of resented that. And then I began to respect this little person, But he worked a long, hard life. He did well, and he lived as he wanted to live in the end.
Yeah.
So that's it, man. That's it.
All right. So I'm looking at the clock. Well, it's just 7. So yes, I should wait 2 minutes and then we'll start. I'm trying to stick to time. So we'll try and wrap up by about 8.
All right.
And then of course it's going to be recorded. It's on YouTube. So those who miss will can watch the video later.
Is this the first time you've done this?
We did one before on hypertension with some members of the Northeast diaspora, and there's a group that's been doing some health work, and we had a Dr. Dunn who spoke about hypertension. So I think the cohort looks at a number of chronic illnesses, so we maybe want to focus on a few of them, over the next few months. And it's kind of a way of improving awareness, because those are a number of the outcomes that we're going to be looking at, and we are dependent on self-report, participant self-report.
Okay, okay. Anything to help spread the word, don't you?
Yes, yes, yes.
I found it was really good in that burnout lecture too.
Yes.
An opportunity to review
Right.
things that make it so complicated in self. And then,
Right.
yeah, and then I did a case study sort of
Okay.
from that guy, Dr. Polanski. You ever
Oh,
heard?
yes, right. Yes. He's in Florida, the Diabetes Institute. So he does a lot of, he's the one who, I think,
It's California.
he's in California.
California.
Okay. At one point, I think he was in Florida too.
Yeah.
But then he's the one who started the burnout. Yes, you've read his book. He has a book on diabetes burnout.
Yeah. So, but interestingly enough, we had incorporated that in the program now.
Right.
You know,
yeah,
has been very useful for me.
I
don't know if you saw the new series of continuing education hours from ADA.
No.
Diabetes is primary.
Okay.
You would wipe them out easily, but I'm taking time because I'm so busy. But I've done 5 of them. Cardiovascular disease and classification.
Right.
Diabetes, renal disease, mental health.
Right. Oh, yes.
Obesity just came out.
Okay.
So I can do that one.
I want to look.
In November.
Yes.
I'll send you the email.
Okay. Yes.
Time is 1 hour.
And they're prepping, I guess, for the diabetes month later this year.
Right. You know, I always like to do these things because it gives me more insight into what I need to be focusing on as I teach, you know.
Right. Okay. So it's 3 minutes past 7. I see I have a number of persons joining us. So I think we can get started so that we can work through the program. So I know people might be watching directly from YouTube, so we won't know who those are. We'll find out later.
That comes.
Yes, yes. But welcome everyone. Welcome to Our Life Talks. It's a series of talks that we have planned, intended for persons who are part of the Life Project. And each month we've been tackling a different health condition. We spoke last time about hypertension, and then this month we're focusing on diabetes. And I'm very pleased to have a special guest with me. This is Andrea Hunt, so I'll introduce her in a minute. But I want to say thanks to everyone who helped to organize the session. A number of the research assistants who you may have come in contact with or seen email messages from, who've helped to promote it and put together the logo and the logistics for this evening. So I'm going to just give you a little brief introduction to the Life Project and share a few statistics, and then we can move into the talk for the day. I started this thing at the wrong point, so I can go organize myself. All right, so the Life Project is an acronym for Living in Full Health. And we chose this because we felt that these really were issues, life issues that were coming up, especially when it comes to non-communicable diseases. So we know that Jamaica has a problem with non-communicable diseases, and these are data from the last Health and Lifestyle Survey done about 5 years ago. And what you can see here is that we have a lot of obesity in the country, more common in women compared to men, and increasing as people get older, so that by the time women are in about their middle ages, about 55% of them are obese. And this means that your body mass index, which is your weight divided by your height, is over 30. And obesity is one of the things that increases your risk of diabetes, heart disease, cancer, and a number of chronic illnesses. And in fact, for Jamaica now, the average body mass index is 30 for women. Obesity is not as common in men, but it is still a significant health concern. And of course, one of the things that we'll be talking about today is diabetes. And of course, with higher levels of obesity, the risk of diabetes increases. And again, because we see the higher risk of obesity in women, we also see that women are more likely to have diabetes at most age groups. And of course, just as you saw with obesity, where there's an increase in the number of people or proportion of people who have the condition with age, we see the same thing, that as you get older, the proportion of people with diabetes is higher. So for women in the 65 or 70 plus, it's looking at about 40%, and for men, anywhere between 14 and 40%. Hypertension is also very common in our setting. And of course, by the time people are in the middle age, about 50% of them will have high blood pressure. And this is a blood pressure of 140/90. And these chronic diseases and these risk factors are the things that are resulting in the majority of deaths that are taking place in the country. If we look at deaths that are in persons over 5 years old for 2017, for women, you can see diabetes, cardiovascular disease, and high blood pressure, as well as other forms of heart disease, are leading causes of death. For men, external causes like motor vehicle accidents and violence may be more common. But after that, then it's the same set of conditions: stroke, diabetes, heart disease. And then, of course, we see our cancers, prostate cancer and breast cancer for women. So because we've always been describing the number of people with these chronic diseases, we kind of want to understand why this is happening, because it's one thing to say that we have so much of this and so much of that, but why is it taking place in our setting? Why is it higher in Jamaica than it might be in other countries? Is it a racial thing? Is it a genetic thing? Is it lifestyle and so on? And the only way that we can begin to understand the role of these different factors is through cohort studies or cohorts or follow-up studies. So what we usually do for these kinds of studies is that we will assess or examine persons at a particular point in time and follow them over time to see whether or not they develop any of the conditions of interest. So one of the things that the cohort allows us to do is to understand the reason why people develop particular conditions. Because if we can see that that was present first, then people with that condition are more likely to develop the disease outcome that we're looking at, then it means that this is probably an important reason for this to be happening. And so it's really an island-wide study. We're going back to communities that were part of the last lifestyle survey, the data you saw me presenting earlier. We're looking for all of the persons who are part of the last lifestyle survey. But in addition to those persons, we're going house to house in the communities that were sampled for the lifestyle survey and inviting persons to volunteer to participate in this study for us to understand what is driving these chronic diseases in Jamaica. And so the study involves a number of elements. There's a questionnaire where we ask about risk factors for non-communicable diseases, and this would be things like cancer, heart disease, and diabetes. We're asking participants to give us specimens because we can go back and check those later, and this would be blood, urine, hair, and nails. We've kind of held off on the saliva because of the COVID. And then, of course, the success of a cohort or follow-up study is for us to know what happens to people over time. And so if participants are to tell us if they develop any of the main conditions we're studying, cancer, diabetes, heart disease, this will be very helpful in our understanding the causes of these conditions. And of course, their continued participation is welcome. So we hope that with this study, we can understand better our own health in Jamaica. Very often we depend on data coming from overseas or other countries, and it's important for us to tell our story. And what may happen in one setting may not really be as relevant in ours. So maybe one factor may seem very important in North America or Africa, but in Jamaica or the Caribbean, maybe other factors are equally important. And we also need to find ways of picking up persons who are at risk or dealing with those risk factors. Because we're collecting specimens, we may be able to detect new ways of identifying persons who have cancer or diabetes or heart disease. And we're hoping that with this study, we can begin to help to prevent and treat a number of non-communicable diseases, not just here in Jamaica, but around the world. So we have a number of partners. We're working from the Caribbean Institute for Health Research, But also we have the Fox Chase Cancer Center and the City of Hope Cancer Center. Dr. Camille Reagan, a Jamaican, and Dr. Kimlin Ashing, a Caribbean, Trinidadian scientists are two of the other principal investigators for the study. And of course, you may have run into some of these persons from the UWI team who've been out in the field working to tell you about the study and to encourage you to participate. So we hope, like this African tree, and that's a symbol that we've used for our LIFE project, that we will begin to understand things from the ground up so we can really make a difference to the non-communicable diseases that we're dealing with in the region. So with those few words of introduction, I'm going to stop sharing my screen, and then I'm going to introduce you to our special guest. So I was thinking about how I was going to introduce her. She said, she told a patient, "We're dynamite." You remember that one? But he was giving us trouble. So I won't get into that. But Mrs. Andrea Hunt, I'm very pleased that she's able to join us today. A number of people may know of her work because she's a Jamaican by birth. She's currently residing overseas. She was here for a while, but her family is there. And so, you know, there's always that tie, that bond. But she manages to keep herself very involved in everything in Jamaica, and has been an active part of so many of the initiatives around diabetes. And that's an area that she's very passionate about. Mrs. Hunt is a registered nurse. She's also worked as a nursing tutor at the University of the West Indies. And she has been a diabetes consultant and specialist in diabetes. One of the things that she has done is that she has brought the education piece to our care, and that was a piece that was missing. So, and she identified it very early from the very first days when she came on the board, and she realized that a lot of patients didn't understand diabetes, and because they didn't understand diabetes, they were not able to manage it and ended up with a lot of complications. And so she set out to change that. She's been training a number of persons in diabetes education, not just patients, but also health professionals, lay persons. And she's building that momentum that will hopefully change diabetes in Jamaica and the Caribbean. And I'm very pleased that she was able to take some time out of her busy schedule of training to join us. I know she never says no to Jamaica, but I can't abuse her. I just have to appreciate her. So without further ado, Mrs. Hunt, I invite you just to say a few statements and to give sort of an overview, and then we can just take it from there.
Whoops, thank you. Thank you. Let me start again. Thank you so much for a very warm welcome. And I'm so sorry I started talking, but let me just begin again. I have enjoyed working with Professor Tulloch Reid and the people of the islands these last 15 years in diabetes, because we have realized that the management of diabetes can sometimes be very overwhelming, and that when you find out you're informed, you're more likely to take charge. So with that said, people need to understand that there are some basic concepts to management. You need to learn a meal plan, how to make healthy choices. You need to learn to take your medication and understand it. You need to be active. And we Jamaicans, I would say Caribbean people, are not perhaps as active as we should be. And then finally, the concept of testing one's blood sugar. Why we do it is because we need to do it so to know where we're going. Diabetes is a self-managed disease. So I teach diabetes self-management education. And we have found that people who are given that information and internalize it, that's the key. They not only hear it, but they internalize it. So they make behavior changes, which is the next step. And then begin to look at what they're doing with their lives. And your life means living in full health. So why not? Is diabetes a death sentence? Absolutely not. One has to understand the disease, work very hard to manage it as best we can, and none of us is perfect. And then make sure that you do things that will protect yourself. So that means taking care of your eyes and your feet, keeping your physician appointments, getting your lab work. And all these come together to make you a better, more empowered human being. So many of us have high risk factors for diabetes, and we're Caribbean people, and you just heard the obesity percentage is high, hypertension is high. So when you put them all together, the ABCs, the A1C for diabetes, the B for your hypertension, your blood pressure, and C, your cholesterol, you become a person at risk for cardiovascular disease too. So in taking care of your ABCs, you can help prevent those complications. And each of us should have that opportunity. That is my argument. Each of us should have that opportunity. So if it overwhelms you, and I said this the other night in a lecture, take a deep breath. Identify to yourself what is giving you this hard time to control your diabetes. It's not mine, it's yours. And then reach out. We're here for you. I work with a group of diabetes educators throughout the Caribbean. They're trained clinicians and they want to help, but you have to reach out to them. So it comes right back to you saying, I need help, and this is the concern I have. And we're always there. We're always there for you. So stop, think about how you feel. Why are you feeling overwhelmed or stressed? And what can we do about it? Because we need to talk to get support. That's the key to diabetes self-management and support. And with that kind of level of motivation, then maybe you can prevent some of the long-term challenges we face, the non-communicable diseases, and especially in young people. If you were to lose a little weight, what if? If you were to cut the salt out of your food, what if? If you were to learn blood glucose testing and get a healthy meal plan, what if? So as I say to people, it is not a death sentence. And I welcome questions, and I'm always here. If you need my email address, you can get it from Prof, but we want to help. We want to help our people live healthier lives. So I hope I have given you some insight this evening, and I'd be happy to answer any questions. And thank you, Prof.
Thanks very much. All right, good. All right. So I'm going to hope that Janelle or Georgia, you can monitor the chat. But in the meantime, there's something I just going to talk. We're going to talk diabetes. And I think it's such an important condition, because one of the things about diabetes is that, you can't manage just one element of it. It's not about just managing blood sugar, because if you do one part without the other, then the patient really doesn't get the maximum benefits. It's one of these conditions where you have to pay attention to many aspects of life, and support patients as they're moving through different phases. I think we could maybe start talking about what diabetes is, because I think some people don't quite know what it is. We just say sugar, but I don't know if you want to comment a little bit about what diabetes is and what it means.
We all need food to eat. We know that. So we eat food, And as you know, it goes into your mouth, it goes to your stomach, it's broken down, it goes into your bloodstream. But the thing to take home is that your food consists of different types of food. So you eat a slice of bread with an egg and a banana. The egg is called a protein. So that's not going to send up your blood sugar in the short term. What's going to send it up in the short term is if you eat that bread or the banana, a fruit, or a glass of milk. So that's where we start. So the sugar from those foods, which we call carbohydrate or starchy foods, goes into your bloodstream. And as soon as the sugar hits the bloodstream, the body produces insulin, which is a hormone from your pancreas. So what's the pancreas? It's an organ that is just below your stomach, just above the small intestines. And so it produces insulin, which is now going to be like a key to open a door on your cells. So as the sugar comes to the cell, the insulin is there, opens the door, and the sugar goes into the cell. And I use that sugar for movement, for life, for health, and for wellness. I need it. So the message is not that you're going to stop eating carbohydrates, is that you're going to learn how to eat it so you have a healthy meal plan. So that's the underlying problem. My pancreas is not making enough insulin.
And then, I mean, the people often may not recognize that they have it too. I mean, there's a couple of things because, you know, the sugars can be up. And we know that once the sugars in the bloodstream are up, it means that the body is having a challenge moving the blood sugar from the blood into the cells for energy. But not everybody who has an elevated blood sugar will have symptoms. And so for some people, they can have it and not realize that it's going on.
True. Sometimes people have diabetes and 5 to 7 years before diagnosis. That's the sad part about it, because people will tell you, I have the easy one. I have the easy one. And I just got diagnosed when really they've had it 10 years before.
Right.
So one has to be very careful with one's health.
Yes. And I mean, I think one of the things we're doing with the project is that we're actually doing fasting blood sugars on the participants who are able to come in. And that is really one of the ways that we can pick up whether or not things are normal, or even before it reaches the point of diabetes, that, you know, you could be heading there. And if you're in the early stages of diabetes, when the blood sugars are just beginning to be elevated before you actually have symptoms, it can tell you that something is going on and that we need to start getting things back on track from now.
Right. And that's easy to do too. And if we can get people to internalize it again and make two changes, increase your activity and change how you eat. To 10 pounds and you will see the impact.
Yeah.
So obesity is not your friend.
And then today I had a patient who said, "Oh, you know, I have the good one." I was asking her, what kind of diabetes do you have? Well, I mean, she had diabetes when she was pregnant. That was the very first time that she had recognized that she had diabetes. And then I said, "Well, what kind do you have?" She says, "Well, I'm not sure," but she thinks it's a good one.
That's a myth. Because as I say to people, that's the one you'll have had 10 years before being diagnosed. Type 1 patient, we diagnose them within weeks.
Yeah.
So there are people who have had no organ damage at all. They just need to learn how to manage this new challenge to their lives.
Yes. Because the majority of patients have type 2 diabetes. I mean, that's the most common one. And that's the one everybody always says, you know, okay, they think all diabetes is the same. I think that's an important thing that we need to recognize, because sometimes I know with the kids who have a different form of diabetes where, you know, the pancreas stops working and we're not sure why. Sometimes people say, oh, because the child is overweight or the child was eating too much sweets and so on. And that one is really, we don't quite understand what causes it, and we're not sure, you know, sometimes why it happens, but it's not really lifestyle related. But the one that's actually most common and the majority of people will have is type 2 diabetes. And that one, to some extent, has a number of lifestyle components. So we know that there's the genetic part, because, you know, if it's in the family, you know, the parents or siblings have it, then your chance of having it is higher. And then, like for my patient who actually developed it in pregnancy, that's a big red flag.
Great.
Mhm.
Men don't understand that. Or perhaps again, we as healthcare providers need to be sure to explain it to them
Mhm.
at the end of the pregnancy, that you are now at risk to convert to type 2 diabetes.
That's right.
If you don't monitor your health,
Mhm.
lose back the baby weight,
Mhm.
be active and try to eat, you know, just lab work, regular annual checks.
Mhm. To see what's going on. And then as I think sometimes, well, people I think are aware of the weight, that, you know, the more you weigh, maybe the higher the risk of type 2 diabetes is. But then the fact that if you're hypertensive, that's also putting you at risk. Or if you have problems with your cholesterol, your good cholesterol levels are on the low side, or some of your dangerous cholesterol levels are high, then those are clues to you that you are at higher risk of going on to develop type 2 diabetes.
And you know, the sad part about that is that people are given medications when they go to the clinic.
Mm-hmm.
Perhaps we again fail to explain
Mm-hmm.
what it is for, when should you take it, and the possible side effects, to come back and talk to us.
Mm-hmm. Mm-hmm. Mm-hmm.
So, you know, a blood pressure pill may make me feel dizzy. So what do? I stop it?
Mm-hmm. Mm-hmm.
The solution.
Yeah, yeah. And then why all of these things are important. I mean, it's important in terms of your risk of problems, but it's also important because we're trying to prevent or it's alerting you to the fact that there may be other problems that could be on stream.
Indeed.
Yes, I mean, so I think those are the common risk factors. But I mean, I think a lot of new things are emerging, which is why I'm excited about this project, because you realize that, you know, where people live may also be important. You know, the foods that people eat are also important risk factors, but those may not have been as well studied or understood as some of the things that we spoke about already: the weight, the age, the family history, that pregnancy. And so there are always new things that we need to understand, because maybe these are things that we should also be tackling. We might be trying to deal with things that we can't change. We can't change the fact that we get older. We can't change the fact that our parents or families have diabetes. We know we can change some things in our lifestyle. We can be more active. We can keep the weight down. You know, we can recognize when we are at risk and monitor ourselves. So there are bits that we can do, but, you know, if there are other things that may also be important, it's important for us to learn about those as well.
Right. It's interesting. A lot of people do not realize that your surroundings, your community contribute to who you are too.
Mm-hmm, mm-hmm.
You know, that if you hear that you drink this grass or that grass as tea, then be fine. And we have to address that as part of our culture. Islands has worked, and you hear the same thing over and over again, you know. That don't take this pill, don't take it, the doctor gave it to you, it's not good for you.
Yes, try this instead. Oh boy. Well, here's a question that came up. So somebody says, Danielle says, I was recently diagnosed with pre-diabetes. I haven't returned to the doctor since I got this diagnosis, mostly out of fear of being given loads of pills. So she heard your question coming.
Yeah.
I know my stomach cannot tolerate. How do I propose I reverse this? I'm only 114 pounds. That's quite light.
Oh, yeah. Yeah. Well, I was going to say be more active, but it sounds like you really are pretty active anyway. You know, so maybe your choices of food would help. You're having too many foods from the starch group at a meal. That could be contributing to this early imbalance. But I'd have to talk to you to find out some more.
Yeah, and then maybe even what test was used to make that assessment, because there are a number of things that we can do to check to see whether your blood sugar is normal or abnormal or high. So, I mean, the most common test that we do is the fasting blood sugar. So usually you wouldn't have eaten for about 8 hours at least, and then we can check your blood sugar before you have anything to eat. And if it's within a certain range, you know, we say that it's normal. If it is above that normal range, it's sometimes in the pre-diabetes range. And then when, of course, it gets to a certain level, then we say you have diabetes. So 7 is what we use for diabetes. I know for our study, we had a little bit of back and forth because, you know, the American Diabetes Association has one standard and the WHO has another standard for what we call pre-diabetes and diabetes. But since we've been using a number of the WHO criteria, we thought we'd just stick to that one rather than confuse persons. But WHO says if your blood sugar is more than 6.1, that's pre-diabetes. The American Diabetes Association says if you're more than 5.6, that's pre-diabetes. So the tests that you do can kind of help you to figure out what's going on. And sometimes people have also done the A1C. The A1C is a test that we've traditionally used mainly for monitoring of blood sugar, but more recently, if you're doing it a certain way, it may also be helpful for diagnosis of diabetes as well. And then the last test that we sometimes use is the older-fashioned test, which is the glucose test. So it's not, and other people come and they come to the clinic and they get a blood and then they go and eat breakfast and they come back 2 hours later. But we're really talking about getting a standard meal because, you know, you may eat dumpling and banana and somebody else eats a sandwich. And so the results for each meal could be very different. So when you get the glucose, it's one way of making sure that everybody's getting the same amount and we can understand what that reading means at 2 hours. So sometimes when you do the tests, you have to know which test it is. And I've seen some cases where one of the tests are abnormal. So for instance, the HbA1c may come up in the pre-diabetes range, but if you do the fasting glucose or the glucose tolerance test, they still are okay. So you kind of have to know a little bit about how that diagnosis was made, and then that would be helpful. And then the comment here is the fasting test was done. Okay, so and so it was the fasting glucose, because remember, you could be fasting and do different tests at the same time. But if it's a fasting glucose, well, sometimes we may want to repeat it, or we may want to do the full glucose tolerance test, where you go back and do another fasting, get your glucose load, and wait around 2 hours and check it again and see exactly where you are. But yeah. But the pre-diabetes is, I guess, the thing, because it's really one of the things that's exciting, because it's supposed to be a point of reversal. And I think that's important, because we know diabetes doesn't happen in one day. I mean, you don't just get up one day and the blood sugar is abnormal. I mean, there are a few people who have that experience, but most times you're kind of gradually moving there. And because you're gradually moving there, you can, if you pick it up early, you can actually do things to get yourself back. Or if you don't get yourself fully back to where you were, you can reduce your likelihood of going on to develop diabetes. And then even if you do develop diabetes eventually, the fact that you delay the time for it to come on is a big deal.
Indeed, indeed. Mm-hmm. Many people don't realize that.
Mm-hmm, yeah.
I can, by using just a simple activity and meal planning, prevent onset of frank type 2 diabetes. It buys me time, quality.
Yeah.
Indeed.
Yeah, because a lot of the complications take place over years. I mean, if you can, instead of getting diabetes when you're in your 40s, if you can wait until you're in your 50s or 60s before it actually comes on, it means that a lot of the complications may never, you know, you may not reach a point where they will be having any significant impact. But I mean, for a young person who's having issues with their kidneys or their eyes at a young age, when you're having your family and you're trying to put a lot of things together, it can be quite devastating.
I guess that's where the overwhelmed state arises. When they're so young.
Yeah, yeah. And we actually have a lot of people developing it at a young age here, because when you look at the data from places like Europe and so on, diabetes is really a more of a condition of the elderly. So, that is 60s, 50s, 60s, and that is when it's coming on. In our setting, we're seeing it from 30s and 40s. That's not good.
And younger.
And younger, yes, because it's like the prime of life, and it really does detract a lot.
Unfortunately, you're still going to have the complications, which means start them earlier.
Yeah.
It complicates your life as a human being. A young woman who wants to have children and get married, she has this disease that she perhaps could have prevented had they understood earlier. So it's really not easy.
Yes.
An easy disease to work. But you just have to fight it.
Yeah. And I think that's where the support comes in, because, people can take two approaches. I mean, they can just say, oh, it's too much, and just give up, or just, not even bother to try. But I think the key is that, if you understand it, and then you understand how each little thing you do can help to make it better, then that really gives you a big advantage. It really gives you a big advantage.
And with this pandemic, there has been an additional stressor on us all. We must take that into consideration. It just makes everything harder. Availability of medication and food, and safety for activity and supplies. So it's even more complicated. And again, like you said, find your support system. Find your support. That's important. You can't do this alone.
Yes. All right. And then, you spoke earlier about some of the keys to diabetes. And I always say that understanding it is really one of the first keys, to understand how everything ties together, connecting the dots. But then the meal plan is important. So for understanding the foods.
On Sunday last, I had a patient who is from Grenada. She described her lunch for me, and I was falling off the chair as she talked. She started with 3 dumplings, and she went on to 2 green fig, which is boiled
banana.
And then she had one called Blugger, and I couldn't figure what Blugger is. And she said, it's a bigger banana. I have one of those.
Okay.
And I have half of a plantain, and a slice of sweet potato. And this is in a peas soup. Where's the beef? There's chicken or salt beef in it.
Yes.
But I said to her, everything you have described to me is a carbohydrate. Every single aspect of this meal is a carbohydrate. And she was under the impression that she didn't need to test more than twice per week.
Yes.
So I asked her if she wouldn't mind doing it after this lovely meal for me a couple of times this week.
Yes.
Sure you want it, nurse?
Oh boy.
And she began to see the dots.
Yeah.
It's just too much carbohydrate at a meal.
And carbohydrates are very popular for us, the bread and the yam and that sort of thing. I remember, Professor Morrison, his favorite story they gave, somebody gave the person a diet sheet, because sometimes when patients come, they ask for a diet sheet. And when he finished, he said, I've had my diet, now bring me my breakfast. So we don't use that word anymore. We don't talk about diet sheets.
Meal plan.
Yeah, meal plan. Yeah.
Meal plan.
And what foods affect the sugar the most,
Right.
and how to make sure that you don't overconsume any of those at any one time. Because also people have the concept that you can't eat this because you have diabetes, you can't eat this and you can't eat that. But if you understand the different foods and which ones are most likely to affect the blood sugar, then you just eat it in the right proportion and you'll be fine.
That's right. There's nothing that a person with diabetes should not eat or eat.
Yeah.
How much?
Yeah. I mean, we still want you to make healthy meal choices, but I mean, there's nothing to say you can't, because once people hear the word can't, then they want it all the more.
Yes, Of course. We're
Mhm.
human beings,
Yes.
human beings.
Yeah.
But it can be managed, and we know that if we can keep that diabetes under some fairly decent control, the long-term research has shown those
Mm-hmm.
complications are not as acute and
Mm-hmm.
not start as early.
Mm-hmm.
So there's bang for your buck.
Yeah. Mm-hmm.
There's
Yeah, and I mean, these are not theoretical, because I mean, these are things that we have seen for more than 30 years, that we know that if the blood sugar is better controlled, then your risk of eye complications, kidney complications, nerve complications is reduced. And then if you add to that, making sure your blood pressure and your cholesterol are well controlled, your risk of heart disease and amputations is significantly improved as well. You know, and I think sometimes people, there's always a bit of tension, because I find that patients don't want to be on medications. You know, you go on it, but you take it reluctantly with the hope that you can come off it. You know, how quickly can I wean myself off these things or go to something more natural? But I always try to say, well, you know, what we're focusing on is a target. So in other words, if you can get your blood sugars to where they should be with your lifestyle, then that's fine. But if they're not where they should be, you know, you're not really doing yourself a service by avoiding medications, if it is that you need tablets or insulin to keep it there, or other forms of medication to support other things. Then it's the most important thing is focusing on getting to those targets, because when you hit those targets, your risk of complications is less.
yeah. And the research has shown that even you can start at any time in the journey. You know, if you just realize that you have diabetes and you recognize it's been like 10 years, but now you take charge.
Yeah.
Take charge at what time you are. Take charge and take charge, you know, and ask questions. We're here to help.
Right. I think that discussion, because sometimes it may not happen all the time, but I mean, if you have questions, it's important to ask, and then and if you're not happy with how some things are going, then ask more questions.
Right.
You know, so I don't. But I mean, just today, I mean, again, the same experience where, you know, they said my blood sugar, you know, I'm going to the clinic, but my blood sugar is still 20 in the morning, and I'm saying, okay, why is my blood sugar 20? And you just get a prescription and say come back in 6 months. I mean, sometimes that's an unfortunate experience, but I think when we recognize that something isn't right, then that is an opportunity to seek care in the right way.
Proactive, you know, if
Yeah.
it's from one person, seek somewhere else.
Yeah.
That's something we're trying to get the word out there, that, you know, you can call in. We have an access number now.
Yes.
You know,
The diabetes educators.
Yes. And we're willing to help guide people through this, because it's not easy.
Right.
Easy.
Yeah, so I mean, we spoke about the meal plan, the activity. We spoke about that. That's very important. I mean, it's not just for blood sugar control, but even also for keeping the blood pressure down and the cholesterol. And in our setting, it's very challenging, I mean, to find, because, you know, everybody's busy. You have long days. You start very early, go late. You know, the commute can be exhausting. I mean, what are some tips that you typically share with your patients to see if they can increase their activity levels?
Well, I'm very concerned about things such as safety and the weather.
Yeah, right, because we are quite hot here too. So you can't even say you're going on the road.
No, and you don't know what's out there. So walking alone late at night, that's not So I am a pusher of, if you have any kind of, if you have a phone that has access, we can send you a video that you do. That's 15 minutes.
Yeah.
And you just watch your phone and do 15 minutes of exercise. We have we also have, you know, you can do things around the house.
Yeah.
You go walking around your yard. I saw my son do that. to try to lose weight. He was 12, and I was most impressed. Somebody had called him fat. He would run around the yard, lost the weight.
Yeah.
And that's the take home. So we can find our own creative ways. And, you know, if you need some help, again, ask, reach out.
Yeah. And I think sometimes you keep things to yourself, but sometimes when you're even talking with other people, they can give you some tips and solutions that they have found have worked. Not everything that works for somebody else will work for you, but I mean, that sharing is very important because you can learn from each other.
Absolutely. And we have chair exercises. We have 15-minute activities. Really get you a huffing and a puffing in 15. And then you can go for a walk if it's safe in your neighborhood. You can do it in the morning early or in the evening when family members can come with you. You know, so you have options, but don't sit. Even when you're at work, get up from that desk and go walk. And just walk around the room one time and come back to your desk.
Yes.
Good things to do.
And then, so we spoke about activity and the eating, and then the medications is another a big area. I mean, taking them, we spoke a little bit about the fact that people sometimes don't like tablets, but I think those sometimes are what we need to keep the blood sugar where it should be, or insulin. I mean, you know, it's not so much about, okay, you failed because you've taken a tablet, or you failed because you have to be on insulin. I mean, that's just how diabetes is, especially type 2 diabetes. It changes. So there may come a point where you may require medications, including insulin, to keep things under control. But the key is that we're aiming to keep things under control.
Absolutely. And I find that sometimes the patients are given, as this lady said, the big pills to take. And the dosage is too high to stop. They start having stomach problems, diarrhea, and nausea. And what do? They stop. Go to the doctor and discuss it with him.
Yeah.
You know, are there other options we can give you? Don't stop.
Yeah.
Get back to target, like you said.
And sometimes going back and letting them know is important, because sometimes they don't realize. Yeah.
We don't want you to stop. We want to get back to that target, because that's when you can prevent complications.
Yeah. And then understanding the medications is very critical, because, you know, these medications are intended to bring the blood sugars down. So if you're late with your eating, or you don't eat on time, then, you know, sometimes they can set you up for problems. So it's really important to understand, you know, which ones you're to take when are the best times to take it: morning, evening, with meals, without meals, before meals, etc.
That is also very important. Some people require a snack before going to bed at night because their dinner is really early.
Yes.
So there's nothing wrong with having a bedtime snack, but to discuss it with an educator to help you. Snack to have.
Yeah.
Their candy bar. So we'd like it to be, you know.
Yes.
Candy bar. And I mean, I think that once you make these behavior choices, it gets easier as time goes by.
Yeah.
And you see your A1C settling down. And
Yes, well, I mean, you brought up the other thing too, which is the keeping of those appointments, because a lot of times you may skip it, or, you know, or something comes up and you say, okay, I just need a prescription. But the appointments are important, because those are the times that you can assess how things are going. The blood pressure is checked, your weight is checked when you come in to see the doctor, or, you know, the nurse, whoever is a provider. They can track those things for you, and you can see maybe how well the things you're doing are working. And then, of course, the laboratory tests are other ways that we also make sure that things are also managed in the right way, because diabetes is more than blood sugar. I mean, we know it's about the cholesterol, about the blood pressure, and these are the factors that make a big difference to your outcome.
And we need to make sure that you understand how to take your medicine. For instance, the other day I heard a story about somebody who's on antihypertensive medication. The doctor ordered one in the morning and one in the evening. But she didn't understand. She's taking one medicine first, and when that one finishes, she'll start the next one.
Right.
And I think there we as providers have failed her. It's, you know, we need to explain. You need this one in the morning, and we need to take this one at night. Take in the two in the same day, you know.
Yes, yes, yes.
You have to make sure your patient understands what you're saying. So we really owe it to the patients to do it right the first time.
That's right. That's right. So we've spoken about the keys, keeping those appointments. I know for diabetes, you know, we're also looking at not just the regular doctor, but the eye checkups, because we want to pick up things early before they get out of control, because the earlier we pick them up, the better off they are. We check the kidney, and that could be, that is a combination of a blood test to check how the kidney is working, as well as the urine, because we can pick up things very early from the urine as well if there's damage from diabetes. The cholesterol is another important thing for people with diabetes to know, because depending on what is happening, you may want to have the cholesterol lower, particularly if you have heart disease or you're at very high risk for heart disease. And then the foot examination, I remember that patient you spoke about, because you used to work on the surgical ward, and you know, these people who are have had amputations.
Yes, yes. I mean, I'll never forget that patient. She said when she sat through the little education session and we talked about taking care of the feet, she said, so why didn't somebody tell me before? I am now preparing for the second amputation below the. This was a 3-year-old woman. And she had had diabetes from she was at least 13, 14. So it begs the question, why was she not educated and given, you know, because we failed her.
Yeah.
We failed those patients. And they get these foot sores, and they've had diabetes a long time, but there's no blood flow to the extremity to heal the sore. Because of the complications of diabetes, you know, so we really need to be empowered. We need to empower patients, and we need to be proactive on their own behalf. So go to the doctor with a list of questions. Write it down, because you might forget. Especially when you have gray hair like me, you tend to forget. My doctor knows me. I'm coming with the questions. You know, and that's the way you take charge of your health. This diabetes is my diabetes. It's not Dr. Tollereed's diabetes. God forbid that he should have diabetes. But, you know, people need to be empowered to take charge of their diabetes. Historically, I have diabetes and the doctor give me a pill, and that's that's not it. That's only part of the puzzle. And we all have to be engaged in self-management. You know, so I push that. I really encourage everyone to get involved in your own diabetes self-care. Information, ask. If one person doesn't have the answer, ask again. Seek it.
And we have information in other sources as well. Hopefully go to the right ones, but I mean, the internet, you know, and other things like that are also great resources. I mean, we get a lot of our things from some of the credible websites. A lot of important handouts and resources that can help to make things easier. And then, of course, sharing with other people. I think that's because it is work. It's not easy. I mean, you know, we say a lot of things, you know, as you said, it's diabetes self-management, because you spend 15 minutes with, you know, or half an hour with, you know, your provider, and then the rest of the time you're on your own.
Who makes decisions? And I find sometimes, for instance, Another situation is, are you taking your insulin appropriately? We talked about pills. Insulin should be administered under the skin, not in the skin.
Yes.
And a lot of people never get taught the right way. You give it before the meal rather than after the meal.
Right.
You know, so make sure you understand when you're giving insulin, when to take it, how to take it, how to dispose of syringes. Throw them in Guyana. I went to Guyana, they were throwing it up on the roof. Syringes. And the rationale is because it's not on the ground, nobody going to step on it. It's washing down when the rain falls.
And getting into the river.
So we had a conversation, and one of the pharmacists there came up with the idea, just the patients are given syringes every month with their insulin. So 30, they bring back 30, so they get.
Yes.
And by implementing something as simple as that, we got a little bit less of the syringes.
Right.
You know?
And being properly disposed.
That's right. So dispose of your syringes appropriately. And use a thick plastic bottle, like one that you get fabric softener in or washing soap. Drop it in there, but don't use a regular water bottle. They're too thin.
Yeah.
A coffee can. You know, and when it's half full, that you can taper on the top and throw that in the garbage, but do not repeat, just throw the needle in the trash. Not good.
Yes.
Yeah, there's so many things to learn about diabetes.
Yes. And each person's journey is unique. I mean, you know, we speak generally, but I mean, the plan is developed for each person. You know, if you're type 1 diabetes, type 2 diabetes, the plan could be different. If you're an older person, a younger person, if you have chronic illnesses, you know, then your plan could be very different from somebody else's.
And sometimes people have changes in their lives. And they need to go back and revisit the whole concept of diabetes self-care again.
Right.
It's an ongoing journey. I call it a journey.
Okay, so Nurse Wilson is asking, for those who take herbal supplements along with their prescribed medication, any special advice? I guess this is coming from her experience working with, talking to some of the participants from the study.
You answer that one, Dr.
I was waiting for your answer. I mean,
supplements like that. I don't know what's in them. You know,
yeah.
I don't know what's in them.
Yeah, I mean, for me, it's really just, let's talk about it, because I don't know a lot of them. And then when patients bring me something that they're taking, then I can sometimes look at it and figure out, okay, this is a supplement that has chromium, and there's some evidence that maybe the chromium could help, or this has something, or it has nothing that is harmful. So, I mean, I don't see a problem with it. But it's important to have that discussion. And it's also important not to replace, because I think that is why the monitoring becomes important. A lot of people feel that once they are not taking the tablets or taking something natural, then you don't need to do, everything will be okay. You don't need to check to see if it's working. You don't need to see if it's, it's like, okay, only when you're on the medications is this important, but when you're taking something natural, you throw caution to the wind, and that's not the case. You want to, so yeah, I think it's discussion. I mean, once you're thinking about it, or you're trying it, or people are sending these things for you to try it, or you hear somebody say, oh, I have this new thing available, and from the mountains, and once you drink it, everything is going to be fine. But I think the monitoring is important. That self-monitoring is important, because you'll be able to pick up for yourself whether this is helping or not making a difference. And then we're always prepared. I mean, diabetes isn't static. So if we do something and it helps, or you do something and it makes it worse, we can adjust the plan to fit in with what is going on.
What about the keto diet? A lot of people are using the keto diet
now. Yeah, a lot of people are on different diets. And I guess it comes back to talking about, what it is you're on. And in some cases, it may not necessarily be very harmful, but and some people on certain forms of insulin, it could put them at risk because there's nothing for the insulin to work on, or who take certain kinds of tablets that are expecting that you're going to have some carbohydrates in that meal, that when it kicks the insulin into the system, there's something that it's going to work on, then you could get yourself in trouble. So I think the discussion is probably the key, especially when you're thinking about this. It's nice to be proactive, but then you also want to discuss to make sure that whatever you're doing, safety is still an important consideration.
And make a list of your medications or your questions. Take it to your physician.
Right.
That's important too. A lot of people need to do that.
Right. All right. So it's 8 o'clock, which is our special time. We've done an hour. I mean, I think we can summarize a couple of key points. I don't know if there are any key messages that you want to leave with the persons who joined. I mean, we rambled on up to ourselves, but I mean, there are maybe a couple of messages that we want to make sure people don't forget around diabetes.
Well, just remember that diabetes, we are a population of people who are at high risk inherently.
Yeah.
We come from a population that we're pretty sedentary. We're not very active, and we're obese. Hypertension, diabetes, cholesterol, those are things that occur in most people in our population. And as you get older, more so. Women more than men. We're obese, very active. So what to do is get engaged with your self-health early. Go to the doctor, you get lab work done. The doctors do it, but they don't give you the lab results unless you ask for it. So ask for it and let's talk about it. What does this mean? My family has diabetes. Am I at risk? Absolutely. Now we're going to monitor either the fasting blood sugar, the A1C, one of those tests that you discussed. And then if I see it trending towards diabetes, as in pre-diabetes, then what to do? Steps you can do to slow down the progression to type 2 diabetes. And then once you've been diagnosed, it's not the end of the world. Management counts.
Yeah.
A good management means you're going to eat a healthy meal plan, you're going to be active, you're going to take your medication or discuss it with your doctor, and you're going to test your finger sticks. Because we don't know how things work unless we look at the finger sticks or the A1C. So it's really a self-managed disease, but we have to give you the information to do that.
And I hope that tonight will be one of those first steps. I mean, for those who may have some results or be seeing results, or you're getting back your letters with the reports for the glucose and other things that you had done. This is a good time to actually look back and discuss these findings with your doctor at the next visit, because you really may be making a big difference in terms of your care.
Yes.
All right. Well, with those few words, I'm going to thank you again, Mrs. Hunt.
And this was fun, and good luck to everyone.
Yes. All right.
And there, I see
one hand. Okay, as we wrap up.
Yeah, you want to tell us? I don't know if she's allowed to talk.
I'm not sure. But we can probably end the broadcast, and then we can stay on to answer her question, since she has her hand up. So thanks everyone for joining, and then we'll stay on to talk with Keisha. Have a good night, and I'll look out for your comments and other things that we can keep in touch and answer some questions on health issues that you find of relevance in Jamaica.